sound.
I'll give it a wee second. Okay. Just, we're now in, the meeting is now open to the public, and the meeting will be recorded and broadcast throughout Parliament buildings and online. And just to remind members, and I think if there's no one coming into the public gallery.
It doesn't appear to be.
No. But you are welcome, obviously, to use your mobile devices as long as they're in airplane mode and are muted, and you're able to connect to the Assembly Wi-Fi. But no, we're not permitted to take photographs or record any of the meeting. So, members, just item number 5 then is committee procedures and practices. So just there's a number of protocols that the committee are being asked to consider. The first one is committee membership. If we can ask members to note committee membership at page 38 of your papers. Noted. Members, the next item is declaration of members' interests. All Assembly members are required to register relevant financial or other interests in the Register of Members' Interests. Details of registered interests are published on the Assembly website. But also to remind members that in addition to this requirement, Standing Order 69.5 states that a member who has a financial interest in any matter or a relevant interest in any matter must declare that interest before taking part in any proceedings of the Assembly relating to that matter. In particular, there is a requirement to declare any interest which might reasonably be thought by others to influence the member's approach to the matter under consideration. Proceedings of the Assembly includes meetings of this committee. So as this is the first meeting of the committee, members should ensure that any financial or other interests which relate to the remit of the committee or which are likely to be relevant to a substantial part of its work are drawn to the attention of the committee. And it should be noted that failure to register and or declare an interest may be an offence under section 43 of the Northern Ireland Act 1998. So just to ask any members if they have any interest to declare. Danny?
Thank you, Chair. Chair, just as is recorded on the Assembly Register of Interests, I'm employed as a Band 5 and Band 6 bank nurse at South and Eastern Health Trust. I have written to the NMC just to make sure that there is no conflict of interest with my inclusion on this committee, and I will abide by any judgment they make on that.
Thank you, Danny. And from my own perspective, just to record, I was an employee of the South Eastern Trust as a social worker, and I've been on a career break since 2020. So just to record that as well. Anyone else? No? Okay, so members, the rules governing the registration declaration of interest are contained in the Code of Conduct and guide to the rules relating to the conduct of members, and that further advice and guidance is available from the Clerk of Standards, who is in room 254 in Parliament buildings. The next section then is committee procedures, and just asking members to note the following guidance paper. So the Guide to the Powers and Operation of Statutory Committees for Chairpersons and Members, which is page 41 of your pack. Guide to the Role of the Chairperson, which is page 64 of your pack. And Guide for Members on the Role and Functions of the Committee Office, which is page 75 of your pack. And just to bring members' attention in particular to the guidance on privilege and matters sub judice, under section 50 of the Northern Ireland Act 1998, for the purpose of the law of defamation, absolute privilege applies equally to the making of a statement in proceedings of the Assembly and the publication of a statement under the Assembly's authority. This privilege also extends to meetings of the committee, and members should note, however, that absolute privilege does not extend to press conferences or statements made to the press. Committee members should be aware of the potential problems associated with discussing a matter that is sub judice, that is, a matter which is being or is about to be considered by a court. The sub judice rule required by section 41 and schedule 6 of the Northern Ireland Act 1998 is contained in Standing Order 73. It provides that any matters in respect of which legal proceedings are active should not be referred to in committee proceedings, except to the extent permitted by the committee chairperson. In such cases, the matter awaiting adjudication should not be prejudiced by comment in a public session of a committee meeting. The rules relating to this are summarised in the Guide to the Powers and Operation of Statutory Committees for Chairpersons and Members that members have been provided with. And just again to draw members' attention to the guidance on the language and simultaneous interpretation arrangements that have been put in place by the Assembly Commission, which allow for simultaneous and passive interpretation of Irish and Ulster Scots spoken in Assembly proceedings. On non-plenary days, the service can be provided at no more than one committee meeting at any one time, and is not available to support committee business on days when plenary is sitting. Members should therefore be aware that it may not be possible to provide the service in response to all requests. Any member wishing to have their comments in Irish or Ulster Scots interpreted during committee proceedings should inform the clerk at least 5 working days in advance of the meeting for which the service is being requested and specify the relevant agenda item or items. Witnesses wishing to have their comments in Irish or Ulster Scots interpreted during committee proceedings will be expected to inform the clerk at the time of confirming their attendance at the meeting. And just to remind members that Standing Order 78 provides that they may speak in the language of their choice. However, where simultaneous interpretation is not provided, as outlined in the guidance, a member who speaks in a language other than English must provide a full and accurate translation of the remarks. Okay. So just the next section then, guidance on timescales for interaction between committees and departments. Just asking members to note the guidance paper at page 79 of your pack, which sets out the timescales for the provision of information and evidence between departments and committees, and was agreed by the Executive and the Assembly Chairperson's liaison group. Under subordinate legislation, delegation of technical scrutiny to the Examiner of Statutory Rules, just refer members to page 85 of your pack, and outline that following the earlier briefing from the Examiner of Statutory Rules, the committee must agree to delegate the technical scrutiny of statutory rules to the Examiner. So I'm just asking the committee's agreement that the Committee for Health, under Standing Order 43, resolves to delegate to the Examiner of Statutory Rules the technical scrutiny of statutory rules referred to the committee under the above mentioned standing order. The committee further resolves that in carrying out this function, the examiner shall be authorised to report her technical findings on each statutory rule to the Assembly and to the relevant department, as well as to the committee itself, and to publish her report. Just asking for agreement. Great. Thank you. The Committee for Health Legacy Report 2017 to 2022. Just to inform members that the Legacy Report at page 91 of your pack sets out the key activities, outputs and achievements of the previous committee, and also highlights a range of issues that I believe this committee may wish to take account of when considering its priorities. Okay. So members, just the next section then is the Department's Health Briefing. Just like to draw your attention to the Department's first day brief at page 123 of your pack, which sets out the background information on the remit, structure and functions of the Department and identifying the key issues that it faces. Also included for members' information at page 290 is the summaries of departmental decisions made during May, August and September of 2023. And I'd like to welcome the Permanent Secretary, Mr Peter May, who will provide an introductory briefing to the committee, and also senior officials from the department, Mr Chris Matthews, the Deputy Secretary, Mr Jim Wilkinson, Deputy Secretary, and Mr Peter Toogood, Deputy Secretary. So just thank you all for attending, and apologies, we're slightly behind time. We've had quite a lot to get through today, so just I'll hand over to yourselves, and thank you. And we'll open for questions after.
Thank you very much. Thank you, Chair, for the opportunity to attend today's committee with my colleagues. Let me start by welcoming you to your new roles and welcoming the return of a Minister of Health, an Executive and an Assembly to reinstate the proper democratic decision-making and accountability arrangements. I'm joined today by 3 colleagues. To my left, Peter Toogood, Group Lead for Social Care and Public Health. To the extreme right, Chris Matthews, Group Lead for Corporate and Resource Management. And to my immediate right, Jim Wilkinson, Group Lead for Healthcare Policy. In addition to these 3 colleagues, we have a number of other members of our senior leadership team who you will meet in the coming days and weeks. I've been asked to focus my comments on the key challenges facing health and social care. I think you will know that these are many and various, but the key theme that is likely to underpin all of them is resource availability. You will know that until the 3.3 billion package agreed with the UK government, we were on course for an overspend of approximately 135 million, and that overspend did not take account of an estimated HSC public sector pay bill of many hundreds of millions of pounds, meaning that in total we were estimating an overspend of over 500 million in 2023-2024. As a counting officer, that is an extremely uncomfortable place to be in. And I want to reassure you that I believe we have taken all of the decisions within our power to reduce the overspend, including setting out a rigorous efficiency approach across the department and all of its arm's length bodies. I would advise the committee that the budgetary pressures facing not just health but all departments are at a higher level than I have previously witnessed at any point in my civil service career. Alongside a severely constrained financial position, we have multiple and compelling demands for additional funding and a range of public services clearly in need of greater investment. In such a situation, something has to give. Last November, I publicly warned that we will never have enough money in health and social care to do everything that we want. The competing demands for extra funding cannot all be met, not now and not in the foreseeable future. Looking ahead, if we had to work on a flat cash basis from this year's settlement and not take account of the £3.3 billion deal with the UK government, we would be facing a pressure for 2024-25 of approximately £1 billion. The main component elements of that are this year's pay rise, the projection for next year's pay rise, the overspend this year, which we believe would run through into next, and additional and new pressures resulting from the likes of inflation, increased drug prices, and growth in demand. In the coming weeks and months, we will clarify that budget situation, and I hope the outcome of the executive exercise will significantly reduce or indeed eliminate the problem. But the other thing to stress is that those numbers are based simply on continuing provision as it is, which we know is under extreme pressure, and not on introducing new or better arrangements. So that means only continuing with those aspects, for example, of the cancer and mental health strategies or the multidisciplinary team rollout that we have already commenced, and not starting the implementation of new things. Allied to the financial challenges are those experienced by our workforce in all parts of our system. I want to pay tribute to everyone who works in health, social care and public safety, as well as to my colleagues in the department for keeping the service running in the most challenging of circumstances. Following the extraordinary efforts during the pandemic, our people now face an environment where, in nearly all areas, demand is outstripping capacity. That is what's driving the increase in waiting lists in secondary care, the increase in the number of unmet packages in social care, and the pressures experienced by our GPs in primary care. We have grown the workforce in recent years, both in medical, nursing and allied health professional terms, but we're also facing a higher proportion of patients who are now over 75, many of whom suffer from multiple conditions and are therefore more complex to treat. That is a trend which demographics tell us will continue into the future. We recognise we need to do more to meet the health and social care needs of the community. Within our primary and community care sector, we're seeking to maximise the service we can provide. This has included MDTs, I've mentioned in some areas, but also a range of pharmacy first initiatives, harnessing the role our community pharmacists can play in meeting demand. A social care collaborative has been formed, very much, again, exploring what we can do collaboratively with the resources we have to maximise impact. The reality remains, however, that demand and the challenges we face across the system will require more than maximising what we currently do. It will need transformation and investment. Given those challenges, we're clear that we need to demonstrate we are maximising the use of the resources we have. Alongside the efficiency programme I mentioned earlier, there's also a major drive to enhance productivity. Measures like the introduction of day procedure centres at Lagan Valley and Omagh, overnight stay centres in the South West Acute, Daisy Hill and the Mater, and the rapid diagnostic centres at Whiteabbey and South Tyrone are all part of the approach to create centres of excellence that can drive high volume, low complexity cases to maximise the impact on the public. I'm sure you'll want to explore in greater detail and question some of the challenges facing the health and social care system. However, I'm only too aware the challenges can appear overwhelming and depressing, and I do want to offer that there is a way through. I and my colleagues are clear that the challenges facing our system can be addressed over time, provided a number of things come together and work on a strategic and long-term basis. I would suggest the key aspects required are, firstly, as I said, to look internally at what we can do. We need systems to draw the best out of the many skilled and committed members of our workforce. Health, social care and public safety employs many tens of thousands of people and additionally contracts for services which employ tens of thousands more. Those people know many of the ways to improve the way our system works, and it's through the maximising of what they can deliver that we will be most effective. Secondly, as the reality is that the internal improvements will not be enough alone, we need a clear and sustained approach to investment over a number of years, which provides the certainty needed to underpin proper planning and delivery, including growing the workforce in those areas where we have a deficit. Thirdly, I would suggest we need consistent and strategic political decision-making which enables the reconfiguration of our services to create sustainable and efficient delivery. I know all of you will have constituencies and will take a close interest in how services in your locality are affected, but I would ask that you do so with an eye to the big picture. The challenge here is to ensure we can deliver for all of our people and that we provide the most timely care we can on a regional basis. We have to be realistic that our hospital estate is fragmented in comparison with that in many countries. As a result, while we need all of the hospitals we have, we need to try to avoid delivering too many services in too many places. One of the consequences of that is that you end up with very small teams where even 1 or 2 people leaving can throw a service into crisis. I want to be clear that no one in the department is dismissive of the natural fears that communities have in terms of whether the greater distance travelled to a service could impact their chances of survival. But we are also driven by a very strong commitment to ensuring that when individuals do receive a service, it is of a high quality and that that quality does not differ depending on where it is delivered. The consequence of small teams trying to deliver a range of services is that they do not gain the range of experience they need of dealing with each of those conditions, and risks therefore can grow over time in terms of quality. In addition, there's also a reality that doctors vote with their feet. They want to be part of large teams where they can grow their skills to the greatest extent and feel they're working in a safe environment. So smaller teams generally find it harder to attract doctors, not least because rotas are often smaller as well. And what we have seen, therefore, is unplanned service change in a range of areas which everybody agrees is undesirable. But that's going to be the continued pathway unless there are decisions taken to reconfigure services to build strong teams in centres of excellence that deliver high quality of care to our population. The challenge is ensuring with the most effective pathways in place for citizens to access those services and that those pathways work. Part of that is about enhancing our primary care and community health functions to shift the balance of care from a hospital-based care model. Acute hospitals should only be for acute episodes of care. Strong primary care and community health and social care improves outcomes for people as well as gatekeeping the impact on secondary care. Alongside that, we need to maximise the full potential of our workforce, including the introduction of new roles, extended and advanced roles to ensure we have the workforce to sustain services and meet the changing demands on our service and improve outcomes for people in Northern Ireland now and for the future. I will conclude with 3 final observations. Firstly, we have had a lot of external reviews conducted, from the Bengoa review around the need for transformation across our system to specific reviews in areas like cancer and mental health. As a result, we have a good idea of what is needed to make change happen. We need the time, the people and the resources to deliver on that, and in return we should expect to be held to account for the extent to which we succeed. A key part of that is being really clear about which things we're going to prioritise to deliver at any one time, because if we try to deliver on everything at once, given the scale of the challenge we face, we will almost certainly fall over and fail to achieve in any area. But prioritisation will mean agreeing some things don't get attention immediately. That will be difficult because there will always be individuals or interest groups who would like to see their area prioritised, and that is entirely understandable. But it is a practical constraint, and it will be easy to identify the areas not being given attention. Secondly, we need to encourage and enable those who deliver services to work together, optimising resources to reduce health inequalities and deliver the best outcomes for all. Similarly, joining up health with the work of the rest of government better could yield significant health and wellbeing outcomes. We have a public health agenda under Making Life Better and a new approach to how we deliver services through the integrated care system framework. Both will provide a good platform to support shared and collaborative effort, but there is more to do to build community and individual engagement with their health and with the system of health. Thirdly and finally, I want the committee to know that we will seek to respond to a timely fashion in response to your requests. But I want to highlight we are facing major challenges at the moment in meeting the demands of 3 statutory inquiries, that on COVID, Muckamore Abbey and urology, and we're implementing 2 others that have reached conclusions. The COVID inquiry is a particular challenge with multiple modules, and we are investing significant amounts of money and people in meeting the requests required of us. And I would ask that you would bear that in mind, and if there is ever any time when we are struggling to meet one of your deadlines. But look, thank you for listening. I'd now hand over to you for your questions. Thank you very much.
Thank you, Peter. I think that's a very comprehensive overview of what is undoubtedly a huge amount of work. And I'm sure members will have lots of questions. Obviously, we've limited time as well, so I'm going to open up to questions now from members. So I would ask people to just be conscious that we want to get through as much as possible, but without constraining anyone. And as well, if we in response, so we can keep it as succinct as possible, because we will have a lot to get through in the course of this mandate as well. Just, I suppose, I'll kick off with a couple of questions of my own, if that's okay. Obviously, the public pay, the public sector pay issue is the one, I suppose, that we've all been very focused on. And I'm glad to see today there's been a positive announcement around funding for that. In terms of what that will mean for health and social care staff, have you any indication at this stage of what that will mean in terms of settling the pay dispute, or where that is at with the department at present?
Thanks for the question. Yes, we've opened negotiations with the Agenda for Change unions. There's been 2 meetings so far. There's a further meeting next week. And obviously we'll be using as our benchmark there the Agenda for Change settlement in England, taking account of previous settlements that have been here as well. There was also a first meeting today with the BMA in relation to doctors' pay, and again there's a doctors and dentists review body report which we would use as our guide. So we have started that process. I don't think you wouldn't ask me to sort of give you a detailed summary in the middle of those negotiations, but I think we all hope that we'll be able to reach a satisfactory position sooner rather than later. I think probably worth noting just that the doctors have not settled in England on the basis of the offer made to them, at least junior doctors and consultants have not. So that may prove more difficult for us. We'll have to see.
Thank you. And I suppose just on the back of that then, domiciliary care is obviously a huge issue right across the board, and is linked to the pay issues that we're seeing right across in terms of recruitment and all of those things as well. I note in the first day brief that's been provided to members, the department is looking at some options as to how we tackle that, because there's a knock-on impact when we look at the capacity in our hospitals, and trying to get people out of hospital is one of the biggest issues that we're currently facing. In terms of that, is there any further detail on those proposals, or when we can expect to see those?
I'll maybe just comment on a specific to do with pay, and then I'm going to ask Peter Toogood to say a little bit more about the detail. So in relation to pay, one of the changes in relation to a very significant increase in the national living wage from the 1st of April will likely have a significant impact on the social care workforce, and it's certainly one of the things that we factored into the sorts of sums of money that I've been talking about earlier on in my statement about the pressures we face in 24-25. But Peter's been leading some work as part of both on the adult social care side and the children's social care side. Do you want to say something specifically about the domiciliary care piece, Peter?
Sure. So, as Peter said, we recognise probably home care or domiciliary care is one of the key challenges immediately presenting to us in the adult social care arena. So for the past year I've been leading, Peter mentioned it, the Social Care Collaborative Forum, where we've tried to bring together colleagues across the independent sector who provide 70% of our home care services, along with representatives from the trusts, from the voluntary community sector, and indeed unpaid carers as well, because they are providing valuable social care services. And we've made a lot of good progress last year in terms of understanding each other's worlds better, because in order to meet the need, the two sectors need to be working seamlessly together. And if we're honest, we're not there yet, but what we've been doing over the past year is providing the context and the environment within which pay, an improved pay settlement will hopefully thrive. We are focusing on fair work as a particular challenge at the moment, and we've established a Fair Work Forum, which is looking at the issue of fair work. That is looking at improving terms and conditions across the sector. It's also looking at whereas that's the initial focus around fair pay and a fair terms and conditions, we want to look at, what does fair work mean in the broadest sense? Fulfilment is quite a big issue. We want one where the workers who work in that sector are heard and that they're represented, and that they feel secure, and also that they can feel the need to progress in a healthy, inclusive environment where their rights are heard. So it's a holistic package we're looking at, again, in the context of looking at what that immediate pay context looks like. What we're trying to do as well as alongside the pay stuff is look at how we increase the capacity for our domiciliary care provision with what we have, which is very much along the lines of the broader thrust across all our services. So we are putting, for example, early review teams into the trust. So we've funded some early review teams who will look at the domiciliary care packages between 2 and 8 weeks after they have been given at the point of discharge, to see if that still meets the needs of the individual that they've received, or whether we can, I suppose, recycle some of that capacity back in to help. So the pay is important. It's at the forefront of our considerations. We're working up in the context of fair work, and we're also putting it in the context of the broader piece of the need to try and plug those gaps that we know are there.
Thank you. We talk around transformation and all of these things, and I suppose being a little bit parochial here, the report that was recently published, the Getting It Right First Time report in relation to gynecology services, maternity services. I suppose we know that there needs to be transformation, but obviously interpretation of some of the reports then can cause a lot of fear and concern. And I suppose one of the issues that has been raised with myself is around the maternity service for Daisy Hill, and a fear around the future of that. So it's just to try and get some feedback in terms of I know that's only a report, but from the department as to where that's going, because I know that the Minister had referenced the report in the debate around the women's health strategy this week.
The key focus for us with that report will be on the recommendations that are reached, and not necessarily on, there's some commentary which I think you're referring to. Mm-hmm. So our focus will be on trying to work through those recommendations so that we can try to improve the service in those areas, because one of the reasons we commissioned that report is that we were aware that we were facing really severe challenges in this area, and by trying to get some experts, essentially experts from England who have the chance to compare with provision elsewhere and so on, it's one of the ways we can short circuit and try and get to the best answer as quickly as we can. I don't know if you want to add anything to that.
No, it is just to add that we have been using the Getting It Right First Time team as a process to give us some information about how we might improve the efficiency of services. As Peter said, our focus is on the recommendations, creating an action plan to implement those recommendations to improve patient pathways and improve efficiency. But it is a report by clinicians, and they're free to make comments, and I think Southern Trust has already referenced that particular commentary and indicated that they have no intention of changing services there.
And that's reassuring, and I think it will hopefully allay people's fears, because I think certainly at the minute there wouldn't be capacity to lose services already in the system, so it is about looking how to improve that, so that is reassuring to hear at this stage. Just a couple of other questions I have, and then I'll open up to the rest of the members. In the report as well, let's talk about some of the capital projects. So again, the Newry Community Care and Treatment Centre and the electricity upgrades for Daisy Hill and Craigavon, if we could just get an update on those as well.
So I know that we committed some money in year in relation to electricity. There's a multi-year requirement of a certain amount each year, and we would expect to be meeting that requirement as we go through. From memory, the Newry Community Care project is on our plan, but it will be subject to the availability of capital. Capital-like resources going to be under significant pressure next year at least, and we'll just need to see what the outcome of the budget is before we can reach any conclusions.
That's all for me for this one anyway. I'll hand over Linda.
Chair's covered some of my questions, so I suppose the main one was, what does today's announcement mean, and if we can get a bit of detail around that as soon as possible. I know you've given us what you can give us today, and I understand you're not going to have a detailed outlay of what that looks like, but it is important we get that, I suppose, as soon as possible. The other thing I would like to see is, you talked about the priorities, and we can't do everything. I understand that, but if we could get what those priorities are as soon as possible as well, so just so that we can look at it and a rationale behind how the priorities were reached, and the plan then for those that come behind them, and how that's gonna be worked out. If you want to answer those before.
Yeah, so look, I mean, on the priorities point, I think the logic is that priorities should be set alongside a budget being set, because you need to know that you've got the wherewithal to be able to deliver on that. While we have a returning minister, it's still a minister hasn't been imposed for some time, and I think it's also reasonable to give the new minister a little bit of time to decide what priorities he wishes the department to focus on in the immediate period. But I agree that within a reasonably short period of time, we need to be able to set those out. I don't have much to add in relation to the pay point. I think we're all pleased that the way is clear now to try to resolve the pay dispute, and we're working hard to do that as quickly as possible.
The pay is important, obviously, but also the work, the conditions, and all of that. And I'm thinking specifically around the domiciliary care workers, and not having that kind of reassurance around contracts and assurance around hours of work and all of that. I think we need to deal with that, because if you don't have that assurance, that's how we're going to lose people. So I suppose in relation to that, then a wee bit of assurance around where we're at with the workforce planning, in terms of not only the recruitment but the retention, and a wee bit of, I suppose, planning ahead, so not just thinking about what's happening in the immediate, but what's happening going forward. And just in relation to that, then, the just in the papers, obviously the percentages that were given in terms of staff in the HSE, and it rising from 22 to 23, but also it gives some figures from 2018 up to 22. I'm just wondering, that's particularly around nursing and midwifery, sorry. Is that due to the rise in percentage? Is it due to additional staff or a reduction in banking? So do we still or have we stayed stable in terms of, we haven't really had any great increase in the numbers of staff working, but there are more permanent or full-time than banking? Do you have an answer to that?
So there are some new roles. So I mentioned multidisciplinary teams, which are in 30% of Northern Ireland currently. Workers in those are employed by the trusts, so count against the trusts. And similarly, I know as a result of the industrial action, which was concluded in early 2020, there were decisions made about changes to nursing arrangements within hospitals, which will have had some impact. So there is certainly additionality. We are looking to reduce reliance on agency staff. That is a core part of our agenda, and has been for the last 12 months. We've made really good progress with social work agency, and with nursing agency we have made good progress in terms of reducing the off-contract use of agency, which is the more expensive element, as you know. But we still have more to do with the core agency. I don't know if you want to add anything, Jim.
Let me just add, in terms of the growth, the overall workforce has grown, and your question, is this offset by a reduction in use of agency or bank? During the same time, we have been spending more on agency and bank. So overall, there has been more investment in the system. Part of that was to do with the increase in nursing places that we've had over the last 3 years in terms of student nurses. But there still are a lot of vacancies in the system. For us, the priority is trying to move into a full-time workforce rather than agency or bank staff. But the other part of that equation, and Peter's referenced it before, is to make sure that we're able to design the work and the process to make maximum efficiency of what we've got, to allow people to do the jobs that they need to do. And I think the other point you mentioned in terms of welfare was we do have a workforce strategy and a workforce plan, and a big feature of that is well-being, because alongside the numbers in terms of people, we've also got quite high sick absences, and that itself depletes the workforce as well. So we want to work across all fronts, the recruitment, the training, the reducing of agency staff to permanent staff, but also looking at well-being.
I agree with that, but I suppose it's just us getting a sense of where that's at. and
We can
again, I'm
provide-
not asking you
yeah.
for that today, but we definitely need to have that because that is such an important part of everything we're doing. The last thing I'm going to ask you is around the capital stuff, and Liz alluded to it a wee bit, but could we get an idea? Again, I know this is all going to be dependent on budget. You can't give us this today, but I think the committee would want as soon as possible to get a sense of what are the priorities in terms of capital budget and where that's going to go, because we know that there are areas that definitely have been left in a deficit where least money has been spent on capital over a long number of years. And I'm not going to mention the areas because I don't want to be parochial, but the truth of it is it's there. It's laid bare to see. It's not about, it wouldn't matter whose constituency or area it was. If it's the truth, it's the truth. So we need to deal with it. So just if we can get a sense of that as well. But again, I'm not asking you, rather than take up time that other people could be asking questions and they might need answer today. Those are the things that I would like to see coming forward as soon as we can get them.
Thank you, Linda. Colin McGrath.
Oh, thank you very much, Chair. Yeah, look, thank you very much. I suppose, Peter, maybe just to start by thanking you and your team in this last period of time, and to your predecessors and to those directors that were in place. 5 of the last 7 years we have not had a government or executive in this place, and it has left to you as officials to effectively run our health service. Can you give us maybe a flavour of the difficulties that has left you, what you've had to face, what decisions you haven't been able to take, and maybe just a sense of how close to collapse the health service has come? I would certainly see collapse as being that the service isn't able to provide a timely service for patients, and that results in them dying. Is that happening, and what can we do to try and stabilise things going forward?
Okay, thank you for the question. I think certainly, obviously I wasn't in health during the first period without ministers, but this last period has been an extremely difficult period. I would say the most difficult in my time in the civil service because of the financial challenges that have been met, and then the inability or the challenge with being able to take decisions based on what the legislation sets out. So, I think that what is lacking in an environment without ministers is there is no programme for government. There's no universally set budget, as it were. So there's no set of priorities against which all of government is going to pull. And then inevitably within the department, I can take decisions, some decisions at least, but a minister coming in tomorrow or next month could easily want to take a different direction to the one that I've adopted. So that does make long-term planning much more difficult, and I think that long-term planning has been one of the things that has been most challenged in recent times. Everyone will use their own language. I would say that all parts of our health and social care system are under severe pressure, and there are always risks that something might go significantly wrong as a result. The system is resilient. I think often people have said we can't. This is so bad we can't allow it to get any worse, and then it does unfortunately get a little bit worse because circumstances don't permit people to do the things that they know that they would like to be able to. So there's no doubt that the risk envelope, as it were, is more stacked than I suspect it has ever been in terms of health and social care, which is why it's so important that we are able to take some of the steps that I've tried to set out. And I know there's broadly a consensus politically about the need to invest in and transform our health services, but how important it is that we try to begin to make those moves sooner rather than later so that we can begin to mitigate some of the greatest risks.
Yeah, and I suppose we continue to reiterate that we would love to see that commitment that nobody will collapse these institutions in the period ahead, to give the stability that you and your senior management team need to be able to deliver healthcare. And I suppose just to echo that remarks, we hear it from the ground that envelope is stacked, that people are finding lots of difficulties, and that if we can find resolutions and solutions, that would be much more helpful. One issue that we had done in the previous Health Committee was that we got very close to legislation regarding safe working practices, to be able to provide a legislative base for that, which would provide the comfort for staff that they will know that going to work, they're going to go and work in a safe environment where they're not going to be under considerable pressures or vacancies which causes pressures to them. Can you give us a sense where we might be now that we're into essentially a new assembly now? Is that something that's still on the table, or do we have to go back to the start again with that, or is it the minister that would decide whether that's a priority, or is that something we as a committee can help to press for?
So we'll be talking to the Minister about legislative priorities for this year and future years. There has been work done in relation to safe staffing, which was a commitment after the nursing strike, which ended in 2020. And from recollection, we are hoping to be in a position to go out to a public consultation later this year. That would then obviously provide the committee with an opportunity to engage around that legislation and then bring legislation forward thereafter. Is there anything you want to add from a workforce?
No, that's really this sort of timetable we're working to. We have been able to progress work, so it's not going back for the start. We've been engaging closely with relevant trade unions and hope to be able to bring forward a public consultation later in the year.
Subject obviously to ministerial input.
Thank you, Chair. Thank you.
Thank you. Diane Dodds.
Yep, thank you, and thank you for the information. I'm new to the committee, so forgive me
Very welcome.
if I ask questions that you probably have heard 100 times before, but I do think some of it's important to put on the record. You referred to the 3.3 billion or the financial package that is important. In that financial package, there's about 34 million set aside to try to reduce waiting lists. Now, we know that we have the worst waiting lists right across the board in the whole of Europe, and I mean, I think if we think of nothing else, prioritising people on waiting lists who are in pain is a huge issue that we all must tackle. So 34 million seems to me a very small amount of money. What is your estimation of the amount of money that is actually needed to bring waiting lists down to a more manageable level? And how do you see that happening? That's sort of maybe the first question, but I do have some others, Chair, if that's okay.
Well, glad you're not starting with the easy questions anyway. What I suppose I would offer is that you're right that 34 million is a small amount to invest in waiting lists, and we can give you some, I don't have them here, but we can give you some illustrations about what sorts of things that would enable to happen or not happen. If I give you some context, up until this year, in recent years, we've been investing 96 million each year in something called a waiting list initiative. Now, in practice, a substantial part of that money has actually been used to deal with cancer and red flag referrals that weren't being dealt with within our system. But that gives you some sense of order of magnitude. This year, we've had to. I took a decision to reduce that, given the budgetary challenges. So 34 million won't go anywhere near addressing the waiting list problem. It would be many hundreds of millions. I don't have a number that I can give you today. It does depend on what parameters you set as to what it is you're aiming to get to, because you're forever. It's a bit more complicated than it looks, because it's not simply a question of just clearing those people who are currently on waiting lists. You have to accept new people will come onto the waiting lists all of the time as well. And so a core part of what we believe is necessary is to get to a place where our system can cope with that level of new referrals on an ongoing basis. And then there is some investment that helps to clear the backlog that exists. What I would suggest to the committee is that it's important not just to look at that in a secondary care context, because actions taken, for example, in relation to enabling those who are in hospital but there's no medical reason for them to be in hospital, would in itself free up space within hospitals then to deal with more elective care than they do at the moment. Equally, by investing in public health and in multidisciplinary teams in primary care, so it should be possible to have a focus on people who are in cohorts which make them more likely, rather than less, to come into hospital at some point in the future, and to try to take action to reduce the levels coming in. So I suppose what I'm saying is I think we need to take a systemic approach to waiting lists rather than just a narrow one about how much money we can throw at a problem at any given point. Welcome though a sum of money would be, let me
I
say.
accept that there is a whole big rounded conversation around waiting lists, but we're in a position where when I speak to friends of mine who are GPs, one of the most traumatising thing that they face is having to red flag a potential cancer patient, but to know that that cancer patient will not be seen for a very long period of time. And I want to know that the department will have some priority in terms of the waiting list, as well as the whole conversation around the waiting list, and I do think that is massively important.
Yeah, so to be clear, it is the focus of a huge amount of work and effort within the department, both within the policy part of the department based in Castle Buildings, and also since this committee last met, the Health and Social Care Board has ceased to exist, and the people who work there are now part of the department in the form of the Strategic Performance and Planning Group, and they too have a huge focus on reducing waiting lists on a whole range of different things. You mentioned cancer particularly. We are facing challenges to meet the 14-day breast target, the 31-day and 62-day targets, but it's certainly not the case that people are waiting very long periods of time. We are doing our very best to...
I suspect if you're a woman who has just been called back in terms of their mammogram or something, any length of time is a very long period. And I just want us to have a particular focus, that we understand that these are hugely important things, and maybe even if someone can write to me about that, or I'll be very happy to have direct conversations around that, because I just think it is
you can be assured that it is, and I'm happy to follow up.
So I suppose, if I may, Chair, just a couple of other things. There's lots of stuff that sort of jump out at me in terms of the presentation, which is important. So again, I think it'd be really, really useful to get an overview of the capital needs of the whole sort of health estate, and to look at that. I am going to be parochial. Craigavon Area Hospital serves one of the widest and biggest trusts in the whole of Northern Ireland after Belfast, and some parts of the hospital are in very, very poor shape indeed. And I do think we need to look at the capital budget priorities. Workforce priorities. Are we going to continue to suspend recruitment of student nurses into QUB and Queen Jean and Ulster? I know that you did it this year, and those places were offered out. So are we going to try to reinstate that? Because it seems if we're not bringing on new nurses, we will never meet the workforce challenge. And I suppose in terms of multidisciplinary teams, lots of people talk about multidisciplinary teams, and I see the value of them. Has there been any appraisal done of the work of multidisciplinary teams and how effective they are or are not within Northern Ireland for those areas that already have them? And I suppose finally to Peter, in relation to domiciliary care, and I appreciate sorting out the workforce is really important. Paying the workforce properly is really, really important. But the sustainability of that private sector is massive, and we do need to look at that. But I'm also interested in the views of the people who are receiving the care. So I speak to quite a lot of people who, I get maybe a maximum care package, 15 minutes 4 times a day. It really is very, very little. And I know in an ideal world we would all like to provide more, but I do think that is important as well. I look forward to engaging with you, and perhaps maybe just some brief answers. Thank you, Chair, for your forbearance.
So thanks. Look, on workforce numbers for trainees, not just nursing, but more generally, I'm afraid the only answer I can give at this stage is that there's a decision that needs to be taken in the context of the budget outcome. I'm sure the Minister, certainly the Department, would like to be able to increase numbers of trainees in a range of areas, but we need to see. On multidisciplinary teams, I would offer there has been some analysis done, and obviously we can provide that to the committee in due course. Another important dimension to multidisciplinary teams is that we believe it does help to stabilise primary care in the areas where they're in place. So we have not seen the same levels of contract handback in areas where multidisciplinary teams are in place. So that is an important consideration. But then, of course, in addition to that, you're right to need and want to see the benefit in terms of health outcomes. Do you want to
certainly we can share some information on the outcomes of multidisciplinary teams to date. We would have that in terms of physiotherapy, mental health interventions, social work interventions, and also the impact they've had on GP time. And as Peter said, the evidence would show that not only do they provide a better service, and our challenge is, because we've been limited by funding, they're only providing a better service where they exist. So there's something about how to get that better service more widely spread.
Well, if we've only 30% of Northern Ireland covered, is that what we're saying?
Yes.
By multidisciplinary teams, we have an enormously long way to go to provide that service. So there's an inequality straight away in how people are treated across Northern Ireland. I do know some GPs that have them. I know some GPs who would love to have them. And I know some other health professionals that tell me they're not terribly sure whether they work or don't work. So,
indeed, and I think I've heard all of those voices as well. Peter, do you want to say something about the social care aspect that
Sure.
the member raised?
Yes, so you're absolutely right. If I come back to the forum that we have put in place, key members of that are the independent sector providers, both individuals but also representative organisations, IHCP for example. And also a key voice on that are the voice of service users, because we are keen that anything we do has to be, obviously we're here for that reason. I think we can be a bit better at that, and we're looking at how we can improve the voice of those service users on that forum. But those two key voices are there and informing the work, because again, such is the scale of the challenge that you've outlined, we can't do it all in the statutory sector, nor do we claim to be. So we for me, it's been about trying to put into practice, and it can be TWE, partnership working together, but this is the reality. We need to involve everybody collectively to get a solution here. One of the key areas that we're looking at, and the work that's going to take a wee bit longer to deliver, is a new model for home care or domiciliary care, because the time and task model that we have at the moment, it poorly serves the people that use the service, and we recognise that. And there's some pockets of good practice that have been trialled in some of the trust areas, but we're looking to see what that would look like, and we've commissioned some work in that regard, and that's one of the key areas of work that we would like to see come to fruition. So it is that area, the sustainability of that sector is a key, which brings back to the points that Peter made earlier around pay and terms and conditions that we can invest in that sector.
Yeah, and I think that's very helpful, even just in terms of the flexibility around domiciliary care. I think that's something, I know even just in my own experience, it's something that just you find that as time's going on, there's less and less that staff are even allowed to do. When you compare back to many years ago when people were going in and setting fires for older people and things like that. But, and that is changing very rapidly, and people aren't getting out of it what they would like. So any sort of flexibility around that, I think, would be very welcome in listening, obviously, from service users, their families, and how it's actually impacting in reality. I have Orlia next.
Yes, thank you, Chair, and thanks very much to the panel for coming to today's committee. So you all know, obviously, the other day in the Assembly Chamber we had the debate on the Women's Health Strategy, and I know that it's referenced within the first day brief paper, as well as the review into maternity services. But I just wanted to ask the question specifically around the maternity strategy, and looking at a refreshed maternity strategy. I know that work obviously previously had to be paused due to COVID, and I think the latest response from the department was that the work would recommence as soon as possible. So my first question is just, has that piece of work started up again on the maternity strategy? I know that Professor Mary Renfrew is also carrying out a review, and you might be waiting until that piece of work is complete. So that's my first question.
That review is pretty well on now, and we're expecting to see the outcome of it shortly. I don't think the maternity strategy is actually kicked off yet.
No, as you identified quite rightly, things have moved on. So we are aware of the need to refresh and renew the strategy, but the priority for us was looking at the safety of maternity services, as are responding to both reports locally but national reports to see what we could do, and that was really the basis of the work that we've commissioned. When that report comes in, we want to check that we've got all the actions necessary in terms of our maternity services, and that will provide a platform to do the strategy. But in terms of commitment, in terms of resource, our priority is the safety of maternity services, the development of an action plan, and then that will lead us into the refresh of a more holistic strategy. It is tied up in a similar position in terms of a women's strategy, but it's looking at maternity services.
Yeah, no, and listen, all that makes complete sense. I understand that the important thing is to action the recommendations that's coming out of those reviews and reports, and then that will hopefully give you a good basis to, look at a future strategy. But it's obviously just to keep it, on a list of high priority, because there's no sense in talking about having this great women's health action plan or working towards a women's health strategy when our maternity services are obviously not in a, they're under severe pressure, like the wider health service. But it was just to make that point and get some detail around that. So thanks for that. My second question was around just looking over the first day briefing paper. I don't know if I missed it, but I couldn't see any detail or reference to addictions. And I'm just wondering what the reason for that was. I know that you can't put everything into your first day brief. And I know that you have the 10-year mental health strategy in it, you have the MTTs in it, and the perinatal stuff as well. But it just worries me that it's not there sort of substantially, and the reason being is that, the massive cost that obviously addiction places onto the health service, it's probably closer to 1.5 billion when you look at the drug deaths and the alcohol deaths. We know that both of those have almost doubled over the past 10 years. The alcohol deaths came out yesterday, I think it was. So I'm just wondering, I know that there might have been some changes as well in your leads within the department, because I know, Peter, yourself, the last time we met at committee, I think you were head of mental health services. I know that the directors recently changed, so Heather's maybe taken over from Gavin. So my question is, where does addictions fall in terms of priorities and the first day brief? And does Heather's role take in mental health and addiction, just so I know who my point of contact would be in terms of, the senior officials within the department who's dealing with these very serious matters?
So let me talk to the first day brief, and then I'll ask Peter to say something about the organisational approach. So I take full responsibility for things not being in the first day brief, because we tried this time. In the past, there's been a very large volume produced that I felt it was unreasonable to ask any minister to read on day one. So I did take a decision to remove some things that were offered for inclusion in the first day brief, and I think that was one of them. It doesn't say that it's not important, it's just that there's a limit to what you can give a minister on day one. But there's been a lot of work done in the space of addictions, and I don't know if you want to speak to it at all, Peter.
Sure. You're right, Orlia. There has been a range of changes since I was last here. So, and again, there's been some recent reorganisation in the department as well. So, as it now sits, in my group, my broader group, yes, I would still have responsibility for mental health strategy, which is Heather's role, but also for the substance use strategy, which Liz Redmond heads up as the Heather's equivalent, essentially, and Gary Maxwell would be quite a lead on that. Yeah. So you're right, in one version of the first day brief, the substance use strategy for alcohol and drugs is referenced. It's at a high level. One of my new responsibilities in the substance use area is chairing that substance use programme board, which the CMO would have previously done. That's part of a broader reorganisation we've done in the department, which has brought some of the policy areas that used to sit under CMO, some of the public health policy areas, alongside into my group, alongside some of the very related policy areas, most notably mental health. So In terms of substance use, alcohol and drugs, that sits with Liz Redmond and Gary, but they're working very closely with Heather in terms of the implementation of the mental health strategy. One example of that is the two pots of money that we have for those strategies. They put that together to fund a particular coordinating post, because there's some I suppose common actions or actions common to both of those strategies, that there's no point two separate bits of the department doing separately. So they are absolutely hand in glove on that one, in terms of making sure that there's a join up and we're maximising what we have to the best effect of both strategies. I think it's helpful it sits under one sort of policy responsibility as well, because it means Liz and Heather are talking regularly as part of my broader team, so they're fully sighted on what's going on in each other's world, so hopefully nothing falls between the gaps.
Okay, thank you. And know that I appreciate that that update, but I would obviously just like to put on record, and again, completely appreciate Peter, because when we're doing our own first day briefs, you can't get everything in there and you have to prioritise. But you know, when we're talking about the issue of addictions, which I know it overlaps with mental health, and it overlaps with suicide prevention and all the rest, and it cuts across all departments. But in terms of a health issue, I think addictions does need to be up there, because you know, we are seeing the deaths increasing in terms of people dying through drugs and alcohol. It's a really, really serious issue, and it's a serious issue that's impacting on, I'm sure, everyone's constituencies around this table. So my final question then... Sorry.
Just on that, I would just say, I take your point in relation to the first day brief, but to be clear, there's been no difference made to what is actually happening within the department as a result of whether something's in the first day brief or not. So I don't want you to run away with the idea that there's been some change made to the level of resource or effort being put into these matters as a result. There isn't.
Okay, that's grand, no problem. And I will raise it with the Minister as well, obviously, of course, is heading up the department. So yeah, my final question then, I know that again, you mentioned earlier with the maybe some pressures on your own resources due to the COVID inquiry and different inquiries that you are involved in, and obviously just the amount of work that you have on. So see, in terms of your own resources and staff and teams, do you still have a dedicated team that would be working on the areas of transformation and health inequalities?
So there are a number of different teams working in different ways on that across the policy areas that Jim and Peter work on. I don't know, Jim, do you want to say something about transformation first?
Yes,
and then say something about inequality?
About transformation on the healthcare side as opposed to population health. Obviously, health transformation went right the way to, you know, the closest part of transformation is helping people live healthier lives to the how do we make the acute system work as effectively as it can. So we do have teams. So in terms of some of the things we've talked about, those secondary care teams, those GIRFT reviews, those service reviews, that's looking at how we actually improve the services and how we organise them. We've also been doing some work on the construction of the acute sector, i.e. how does the hospital system work? And we've talked about some of the service collapses, looking at how the system should operate as a network and how people should be able to access that care. Primary care is all about the areas of multidisciplinary teams, but it's also about GP contracts. So there is actually transformation work progressing across all those fronts to try and move us forward and deliver it as a pace that we can. So whilst funding is critical, whilst the pressures we're facing are critical, we've maintained a focus on transformation as being one of the answers to help address some of those problems.
In terms of the health inequalities piece, again, that's part of the, I suppose, the broader population health policy remit. And again, Liz and Gary, who I mentioned earlier, have responsibility for that. So, and that's in the context of the Making Life Better strategy. So that's our overarching, it's the executive's overarching strategy for addressing health inequalities. So that work is taken forward as part of Liz's team, and that obviously includes reaching out across other departments, because clearly, you know, health inequalities, the health bit is only part of it. There's obviously a load of other social determinants that have an impact on somebody's health. So we do have I suppose, a dedicated team looking after that Making Life Better programme of work, and that's still there.
Thank you, Peter. Chair, just to finish, I think it might be a good idea I would like to suggest that the committee maybe gets some form of update from those two teams, transformation and health inequalities, at some stage, if members are content. Thank you.
Yeah. Thank you. Nuala?
Thank you, Chair. Thank you very much for the presentation, and we have had a few days to have sight of the first day brief, and I think it was helpful informing discussion here today. Obviously, it's been a long time since any health committee sat, so there's a number of questions that we all have, but I'll wanted to kind of stick to what's pertinent today. And of course, I recognise the difficulties with regard to resources and the difficulties that places civil servants and has done for the past 2 years under. So I just wanted to thank you for the work that you've done in the absence of an executive. And moving forward, hopefully, that now that we have an executive, we can do the changes that are necessary. And I recognise that we can't do everything all at once, and it would be unrealistic to make those promises too. But I just wanted to ask, following on from the discussions around the budget, that of course things have to be budgeted, decisions need to be made, and often they are quite difficult. And you spoke quite a number of times, Peter, about maximising resources that you do have. And unfortunately, we have seen in the number of months is cuts to services, and in particular to the likes of charities and services like the cancer support services and mental health support services, for example. But one thing that we're not seeing though is mitigations to that, because obviously when there is a cut to services where they undertake the work of any other statutory health body should do, that's just going to transfer the workload back onto statutory services. So in terms of the recent decisions that have been made, in what context are mitigations looked at in the impact on the health service again? Whilst recognising, yes, that there is a need to work with the resources and the budget that you have, but where are the mitigations and at what point are they coming into play here? Because we are seeing a lot of contact from community and voluntary organisations and umbrella groups that they're just essentially shifting now onto the statutory sector. So where does the mitigations come into play in that?
Okay, so thank you for the question. And the two examples you gave are actually a bit different in nature, so might be worth saying a little bit further. So start with there was a number of funds established during COVID for cancer, mental health, and for carers. Those funds are projected to end at the end of this financial year, so in other words, at the end of March 2024. So there hasn't been a reduction yet, but clearly there is a risk, budget-related risk in relation to those funds. And I met the Community Fund and one of the providers of those services only a few weeks ago, just before it was clear that the executive was returning, as it happens. But that was a COVID-related fund. It was a fund established for a particular purpose and a particular time. So, it was always time-limited in nature. The other example you offered was around the core grant funding to the community and voluntary sector, where it was a decision that I took this year that there would be a 50% reduction in that core grant funding. And I think from, I don't have the numbers in front of me, I think it was around 1.75 million in total that was reduced. And I guess that was in a context where we were facing a very significant overspend as a department. We did not cut the services that the community and voluntary sector provide directly. They amount to many tens of millions, both within the department and within trusts. We provided, in answer to a number of MLAs, some of that figure work. So as a proportion of the overall spend on the community and voluntary sector, it is actually a very small proportion. I do understand and received a lot of representations from that sector about the impact that has, because the core grant is one of the ways in which they're able to both hold their corporate responsibilities together, but also engage around public consultations and other things. But I suppose what I'm saying is it was kind of the least that I felt. I tried to mitigate it as best as I could, and there wasn't an additional mitigation that I could identify on top of that, which is why that decision was taken. And I was clear at the time, and have been since, that it's a decision I would rather not have had to take.
Thank you for that, and I respect that it is a decision that you should not have been in place to have made. Unfortunately, we were in the situation that we could not control. And I think going forward, obviously, regarding the budgetary pressures, those mitigations in place would be something that the committee, I think, would be looking forward to kind of seeing in terms of shuffling people around the health system. It does happen whenever there's cuts to any services, whether it's statutory or not. So I think those mitigations are important. I just moving on to my next question, and it's a supplementary question towards one, I can't remember another member who'd asked it here, but particularly around the services that are provided under the domiciliary care packages. And I respect that there's a lot of work going on there, but I just wonder if you could give us even a quick review into, or a quick response as to whether you are reviewing, I think it was Diane yourself, you'd asked it actually, around in particular the 15-minute packages, was yourself that asked, because I don't think it was clear as to whether that was part of any review, the kind of expansion or removal or individual nature of that, because it is something that is brought up, that this kind of 15-minute house call is not sufficient. I appreciate that might be a quick response, so I can go
well, just on the mitigations point, I mean, I think, I agree that where mitigations are available, we should be looking for them, but it's unrealistic to think there's always going to be a mitigation. In other words, that you can make a cut, but it doesn't have any impact on the service user or on the service to be provided. I think we do need to be honest about that. That is the risk environment that we're operating in, because we have reduced spend in all sorts of areas in order to try to live within the envelope that was provided this year, and we have not succeeded in that. So, I just wouldn't want the committee to run away with the idea that there was always something that could be done that meant it wouldn't have an impact, because I don't believe that's realistic. Peter, I think you were clear that there is a review going on in relation to...
Yeah, so the work in relation to, I suppose, the design of a new model for home care is part of that broader piece of work that's happening under the Social Care Collaborative Forum. It was an area of work that the members of that forum felt that it was important that we looked at, appreciating it's not a quick fix. So we have to, I suppose, ride the challenge of meeting the here and now and the system we're working within now to try and maximise what we can get out of that. And we've got some initiatives in place to try and do that, while saying, okay, well, this is the direction we're going. That's where we want to head to. And I think at South Eastern Trust have piloted a model around an outcomes-based domiciliary care package, which is around, again, it's more intensive and it's a very small area, but it's producing good results. So the question has to be, is that something that would work more broadly? And again, what would it cost, and how would we get to that whilst dealing with the here and now? And because that is the challenge we're facing, is dealing with the here and now, but also planning and making a change for the future. So that's part of an ongoing work. We are using the Innovation Lab, I think, in DOF at the moment to help us with our thinking around that and putting it all together. So.
Okay, and I'd be interested to hear more at another time around the South Eastern Trust, did you say it was?
It was, yeah,
I'll
but
be
we can
interested to hear
confirm
about
that for you, but I think it
moving
was.
forward. Another question that I have within the first day briefing was the Children's Social Services, the Ray Jones report, and I understand the consultation, I noted, closed back in December, so I just wanted to get a bit of an update regarding if, in terms of what is brought forward, will include an action plan around implementation, so that it's not something that we have yet another report that sits on the shelf and nothing's done about it. Will it actually include an action plan? And I understand, again, resources is an issue, but not all of the recommendations. Some of them are policy and practice based, so there could be things that kind of can move quicker than others. So if that is due imminently, and whether it will actually include an action on implementation.
So, I mean, it was a very heavily, there was an awful lot of responses, over 130, I think. So, I don't know, Peter, do you want to talk through? I mean, there are certainly things that we are looking to do more quickly, and some things we didn't consult on that basis. But it does take a bit of time to make sure we review properly all of the responses that we've received.
Yeah, so as Peter said, 134 responses to the review. I think that was due in part to a recognition of the challenges facing children's social care, but also due to the I think it's not unfair to say the charismatic engagement by Professor Jones himself in terms of how he was widespread and how he engaged with the various stakeholders. So yes, we are going through that at the moment. We did ask 66 questions on about 50 of those recommendations. Yes, you can see the pain on your face in terms of having to respond to that. So, and again, we've done some of the number crunching in terms of the quantitative piece around it, but as you can imagine, a lot of our responses, they were quite hefty. Some responses running to 50 pages of narrative. So that's where the time is taking at the moment. So we are analysing those responses at the moment. The aim is to have that consultation report finished by the end of March, which will include an implementation plan. When I say that, we're not sitting doing nothing, because we know that the issues in children's social care are significant and serious. So we have, similarly to what I said around adult social care, we have put a children's social care reform programme in place as well. And again, with the aim of bringing people together who can influence some of the challenges that are well known in the system. And Ray Jones was very good with us in terms of engaging with us throughout his review, so we knew what his emerging findings were. So we will having an implementation plan. We know that it'll include things around residential placements for look after children, about doing a needs analysis, for example, and then, well, how do we meet that need? There'll be stuff around the fee framework for fostering, because we know that's particular pressure in terms of recruiting and retaining fostering placements. And then there's also issues around workforce and children's social care as well, which we'd want to be taking forward. And picking up on your point around voluntary and community sector organisations, we recently engaged with, I think it's the Reimagine Children's Collective, which is about 8 voluntary community sector organisations who have come together in response to Ray Jones's review, because he recommended the voluntary community sector need to be more joined up in terms of their engagement with us. And we had a very it was either last week or the week before, had a really good engagement with them. So we want to, really formalise how we engage with that sector in delivering against that. So that'll be one of the key actions we'd want to see come forward as well. So there's a flavour of what I anticipate coming through, not, obviously subject to what comes out of our analysis of the recommendations.
Thank you. It does seem like there's a lot going on there at the minute, so I look forward.
There'll be some of the recommendations that were very much for ministers and the executive to consider, and it may be that it will take longer, I think, to address those issues. It's obviously subject to our ministers' views.
So there's probably 2 around. A lot of people had views on whether there should be a separate arm's length body for children's social care, and then in conjunction and tandem with that, should there be a minister for children. So again, that's a longer term thing that we'll need to bring to our minister and to the executive in due course.
Thank you. And I guess under social care again, I wonder if you could give the committee, because it has been some time, a little update on, it was in the first day brief, the Muckamore kind of resettlement, and in particular, if you can expand any more on the adult safeguarding bill. I was one of the responses. I know it mentioned in the brief about the exploration of the mandatory CCTV. In particular, a lot of families said had that CCTV not been in place, they wouldn't know, the extent to which their loved ones have actually suffered. So I wondered if you could expand on where we are at the minute.
Yeah. So in terms of Muckamore, as you're aware, Peter took a decision last year that the hospital would close by June of this year. Currently there are 24 patients still within the hospital. We anticipate 14 will be resettled before the summer. There's another 5, the remaining 10, we are less sure of the timescales in relation to those. But again, we have a dedicated oversight, I suppose, resettlement board that's chaired by Patricia Donnelly, who's working closely with the trusts in terms of sourcing those resettlement options. So that's a really important job of liaising between the trusts and the independent sector providers or the voluntary community sector providers who are providing those resettlements. So that work is underway. In terms of adult protection bill, the drafting of the bill is well developed. It's almost complete. We are looking at the costing of that at the moment, and again playing into what we were saying earlier. whatever the business case for that comes out as, we'll need to consider that in the context of our budgetary settlement. The CCTV aspect of that, you're right, when we consulted on the Adult Protection Bill, that wasn't part of the consultation, but it came through very strongly as part of the consultation and as part of the members of the Oversight Board in the department who have been overseeing the development of the bill. And the bill is drafted at the moment. We'll need to put to our minister because he didn't see it whenever it was consulted on. But I think the proposal at the moment is around not mandating the use of CCTV, but giving the executive the power to legislate, to regulate CCTV in those settings where vulnerable people are being housed. But again, we'll need to take that to the minister and he'll need to take it through the executive because that wasn't part of the original consultation. So that's well developed. Again, we're now in an affordability consideration in that regard as to when we bring that forward.
Thank you. I'm sure the chair wants me to move on. I have like 10 more questions, but
Danny and Alan might want to do. Danny and then Alan Chambers.
Thank you, Chair. Thank you, and thanks very much for all of you coming in today for the presentation on the first day brief. It was incredibly comprehensive, and we've been touched on a lot of different issues. And in fact, a lot of the questions I was going to ask have been asked by other members, which obviously is very encouraging. We have a committee here with a lot of shared priorities, it seems. So certainly that's very good. The waiting lists. It's just unnecessary suffering. We are seeing predominantly older people suffering in their homes, and it really just is unacceptable. It really horrendous, unnecessary suffering. The pay deal, it's great to hear that the way is clear for resolution, and a lot of us will have stood on picket lines with healthcare staff freezing, pushing for fair pay, and that's something that they're very loud about. It is affecting their daily lives, so it's great to see that that's moving forward. The domestic domiciliary care packages, personally, as a nurse, I think that's transformative, and it will be transformative right across the whole system in that you'll be able to have patient flow easing a lot more through the hospital, reducing impacts in A&E departments, and even on GPs as well. So there's a lot with the domiciliary care package that will relieve pressures on other areas. So it's great to hear your comments on that it certainly is being taken forward in quite a serious way. Safe staffing, I think it was Colin who had mentioned safe staffing. It's a key issue for nurses, absolutely key. The pressures that they're under when they have increased numbers of patients, it's incredible, and for safety for the patients, for the actual working conditions of the nurse involved as well. So I'm very grateful that is being taken forward, and I would hope to see it delivered during this mandate. As I said, I do have personal experience of the pressures within the health service, and it is worsening and worsening and worsening, and we do have cases of burnout, and we have had nurses that have left the profession because they simply can't do their jobs anymore. It is affecting their own health, and that's the situation that they're in, despite working through breaks, doing extra hours, coming in and doing extra when they're asked. There is a lot of pressure on them. We did have a situation in November 2022 where one of the A&Es in the Northern Trust actually did close its doors. So I know, as Colin was saying, we were on the verge of collapse. That A&E did stop taking patients on a Saturday night. So for the people in the area, an incredibly frightening prospect that their A&E wouldn't be able to service them if they needed it, and that the system is incredibly overloaded. So we've covered quite a lot here today, which is absolutely great. And it was great to hear Orlia, I think I had mentioned addiction services is certainly something, I know we have a shared interest in it just with the APG. So a huge impact on many families right across Northern Ireland. I did have one question just about something that I didn't see was in the first day brief, which was, I know you'd mentioned it there today, Peter, unpaid carers. Now we have, I understand, around 290,000 unpaid carers across Northern Ireland that are doing a lot of work looking after loved ones within their houses. I think this equates to around about £5.8 billion worth of work. Now obviously care strain is a really, really real thing that they can find themselves under a lot of pressure. They can find themselves financially under pressure, and they can find themselves strained as well. So the first question was just to ask, what are we doing for these carers? And 1 in 3 of these carers, from a recent survey from Carers NI, has said that they haven't had a break in years. So I know there's legislation going through Scotland at the minute to try and have a protected right for carers to have a break, so that they will be afforded a break, a regulated, protected break, and can have respite for the person that they're caring from, in order so that they can relieve the strain and things of caring for somebody. Is that something that has been considered within the department at all? Or what else are we doing for those unpaid carers?
You're absolutely right, Danny. We recognised quite early on when we put the collaborative forum together that the unpaid carers were a key to delivering social care, and I'm familiar with those figures as quoted by Carers NI. We're delighted that Craig Harrison from Carers NI has joined the forum to be that representative who will articulate the views and the needs of that sector. And again, he's taken that role on our forum because as a representative, not just as Carers NI, but of a broader collective that they have put together in that sector. So Craig and a colleague from the department are heading up one of our key work streams under that forum around unpaid carers, and Craig is working with our colleague to develop what needs to be done. Well, we know what needs to be done. There's stuff around the carers register, there's stuff around respite and support, etc. But again, we are operating, as we've heard today, in that sort of resource constrained environment. So that work stream is bringing forward, well, what can be done within those constraints. I think there is some immediate work around improving the carers register as a first order issue, but we are aware that the carers strategy is way out of date. I think it's 2006, and that would be a key, I suppose, piece of work that we'd want to look at in terms of how we take it forward. But again, and we can come back to you on what the priorities of that particular work stream are, but I can assure you they're at the table playing an active role. I'm delighted they are, and we're trying to get some immediate actions that can be taken forward in the resource constraints. Again, mindful of what we do need to look at that broader strategy that's well out of date.
Thank you very much. I had a second, just a question just on a different service, just with GP elective surgical services. I know they had quite a cut recently. I think it was in August, and recently the vasectomy scheme, the GP vasectomy scheme, had been cut completely. Now, obviously, I think as Nuala had said about mitigations, all those people who would have taken up on the system and been through the system where the procedure would have been done cheaply within a GP surgery now will not be able to do that, and they'll end up on a hospital waiting list for years. So obviously cutting that service where the procedure was done cheaply within a GP surgery will now relate to people being added onto longer waiting lists for years and years for a procedure that is more expensive for secondary care to deliver, unless the person obviously goes and pays for it privately. So is there something to look at here about long-term potential savings like that? I thought that scheme was a great example of how you can do a cheap procedure and then relieve pressure on hospital services and hospital waiting lists. Is there any thought of looking at that again in order to help bring the waiting list down and take costs away from secondary care?
So thanks for the question. I mean, we will be looking at all issues in the context when we know what the budget is as we go forward. There was a reduction in the amount for GP elective this year, and that was on the basis that while, as you say, it's an important service for those who receive it, we were looking at overall in terms of prioritisation, and at the time we were reducing the amount being put into the waiting list initiative, which would be dealing largely with more serious cases where the intervention would be more life-changing in nature for people, and it felt again a decision that I felt obliged to take given the legal responsibilities placed on me, that you had to take some account of the seriousness of the issue in the context. But I did meet the GPs responsible for the service They did impress on me the importance of the GP elective service, not least in terms of for GPs who for them it's a motivating factor to feel that they are also able to keep their hand in doing some of that elective work alongside the day-to-day work they do seeing patients in primary care. And that's why we arrived at the decision we did, which was not to end it entirely, but to retain some of it. The vasectomy service has been paused, and a decision will need to be taken about whether to restart that or not. That's in the context. I know that vasectomies are not delivered in all parts of the UK, so it's a decision that needs to be taken and will now be taken at a political level.
Thank you, Danny. Alan Chambers.
Thank you, Madam Chair. Peter, I want to place on record just my appreciation for the briefings that you gave during the suspension of the Assembly. They were very helpful. Earlier in your opening comments, I think you said something along the lines that we would fall over and fail if we try to do everything at once, basically. And I believe that's a very fair and accurate comment. So we may need to really harness expectations going forward. Transformation, obviously the elephant in the room can be local resistance to major change. And if Bengoa is a model, or an updated version of Bengoa is the model that we use to go forward, we'll have to recognise it's not going to be an overnight project, and there will be structured implementation of that as that process is happening and been delivered in the greater public interest. So we may see the local campaigners and the placards out, and I get that, but is there a case for the Department mounting a robust and widespread public education exercise just to explain what transformation is about and what the benefits that it will benefit everyone in the long term?
Thank you for the question. You referenced the briefings, and just for those members who may be wondering which briefings you're referencing, I had offered briefings to the spokespersons of the 5 main parties, and so 3 of the 3 individuals were were attending who were on this committee, and other parties were represented on those briefings. So, and we held those every sort of 4 to 6 weeks, I think, during the period. Second point you made was around not being able to do everything, and it picks up partly at least on what Danny was saying, where you were saying it's great that you're doing work in all these areas, but if you start adding up the cost of what would be needed to implement in all of those areas, then we have to be realistic here and say there's no prospect, not only in money terms but also skills and capacity terms. You understand, as someone who's worked within health and social care, that there's only so much change that people can take at any one time, and we need to be really careful and thoughtful around that. But your fundamental question, Alan, was about engaging the public around transformation, and I do think that that's something that is really important. I don't know, Jim, do you want to say something about some of the work that we've been doing around that, and how, if the Minister chooses, we might be able to take that forward?
Yes, you'll be aware from some of the briefings that we've been looking at aspects of transformation, and as we described it, transformation as per Bengoa not only was about the hospital services, how they're organised, but also was about care in the community, about primary care, but particularly looking at how the acute sector is organised and what transformation might mean for it. We've been working very closely with clinicians, with trusts, to sort of understand beyond Bengoa, what do we mean in terms of what we talk about transformation. And really the narrative that's coming there is we need sustainable services that meet the needs of the population, and some of that will be creating centres, and we've already talked about it, elective centres. Some will be about specialist centres, which might only happen at a regional level. Some will be about what the hospital or the core services a hospital needs to provide that meets the needs of its community. But actually the real challenge is how does that work, and how that will work is actually more about cooperation. It's more about workforce deployment. It's more about pathways and understanding patient pathways. So we've moved quite forward in that debate. We've moved quite forward in that thinking, to the extent where we, subject to Minister's views, we would be in a position to start engaging the public with, well, what does your hospital provide? How does it fit in with the network, and how does that network work effectively in a transformed system? we'll be taking those thoughts to Minister shortly, and that may well start the opportunity, because I think it is about a narrative, it is about engagement, it is about the public supporting that view of transformation, not about a transformation that doesn't mean anything. So that really is a critical phase of it.
No, I think the public aspect is very, very important. The other question I wanted to ask was, Diane had asked about waiting the lists and the unacceptable length of waiting lists at the moment. Obviously, we have to recognise they weren't helped by the 5 years of suspension that the Assembly underwent, nor were they helped by the COVID epidemic, obviously. But we talked to her, Diane mentioned about 34 million for to try and address the waiting list issue. And Peter, when you were sort of pressed on it, you said there, and I realise it's not all about money, there's all sorts of aspects, but you said that it would take hundreds of millions to bring waiting lists down to what would be considered to be normal levels. Now, if tomorrow somebody transferred those hundreds of millions into your account, what would be your best estimate of the time scale to bring waiting lists back to acceptable and normal levels?
So it does depend on how you define what acceptable and normal levels are. So I don't want to sort of give an answer off the cuff there without having worked it through. There is a lot of work being done within the department that has looked at how you could, for example, look to bring down to make it that those who are currently on waiting lists, that no one is needing to wait more than a year. And there's a projection that we did offer last year around that, and I would need to go back and check that that's still an extant projection, because it was some time ago that I last saw the number. So I don't want to mislead the committee. I think what we need to understand is that there would be there's some scope always to flex resource within the system to invite people to work different patterns, longer patterns, additional shifts, as it were. So there's some scope that way. You're then looking often at the independent sector as the second way in which you can flex capacity. And anecdotally, at least, the independent sector is a lot busier now, because the reality is that some people, where they can afford it, even perhaps where it's marginal, are seeking to get private care, and that's obviously unfortunate and something that we would like to be in a position where we could meet that through the health and social care system. So what I suppose I'm saying is we'd also, in addition to doing a piece of work that says you can do X amount, you also need to be sure you've actually got the people there who can deliver the X amount. So there would be a scaling up needed, and that's why I'm reluctant just to offer you a date off the cuff.
When I said earlier about harnessing expectations, I mean, are you talking months?
No,
or we're talking a period of years?
Yeah, it's definitely years.
It's a period of years before. Yeah, okay. And just my final point is if you could maybe give us a quick update on the challenges maybe been faced by some of our trusts in relation to the introduction of free car parking on their sites.
Okay, I'm actually going to, Chris has nearly got away without having to comment today, but I'm going to ask Chris to talk about that one, if that's okay.
Sure. So I suppose the biggest challenge in the car parking side of things is going to be the logistics of managing a free car parking service. So essentially, if you can imagine you make something free, it's going to attract a lot of people who want to use it. Those hospitals that are in areas where are near the places where people work. So you're going to need traffic management systems. So we've estimated that's going to be something like 9.5 million a year to manage the sort of flow of traffic within car parks across the system. And we're having some issues there with procurement of those systems because they're quite unique. So at the minute, the procurement is being challenged by 2 potential providers. So we're going to have an issue there around even getting those systems in place before the legislation goes live. So you might be in a situation where the trusts are having to find people to put on high-vis jackets and go out into the car park and try and sort of manage the cars as people are parking in. So there are some pretty significant logistical challenges there. essentially to make sure that the free car parking provision is going to patients and staff members as opposed to just generally people who want to use free car parks.
Thank you. Thank you, Madam Chair.
Last but not least is Alan. I know Linda and Diane wanted to be small point at the end, if that's okay. But Alan, you will.
Just a couple of comments.
No worries, that's fair enough.
Bringing us back, I know it seems like quite a long time ago when Diane had asked the question around and posed the question direct to yourself, Peter, about the cost to try to tackle waiting lists.
Yeah.
And you talked about hundreds of millions.
Yeah.
And I'm looking just at an Audit Office report back, and it had indicated back then for a plan from 2017 to 2022 that was estimated at 909 million. So I assume now we are now talking telephone numbers.
Well, certainly waiting lists have got a lot worse since that report was written.
Just another comment on, I mean, when you speak, in your official speak, Peter, we all listen. And whenever you talk about transformation, I don't think there's anybody in this room that doesn't agree that we need transformation. I don't think there's anybody in this building that doesn't recognise that we need transformation. But there is some messaging, I'm going to get down into the politics of it all. Sometimes, whenever, for example, Causeway Coast Hospital, or Causeway Hospital, you will see a negative message constantly being across the headlines. You'll see maternity hubs being created in Antrim. You'll see, as one wise old owl had once said, that whenever there is a road travelling from Causeway to Antrim or Belfast or beyond, it's a two-way road. But unfortunately the traffic tends to be only going one way. And when you get down into the politics of it all, it can be quite difficult for ourselves to try to argue the point to people, that the importance of transformation. Whenever they see a one-way road and a one-way system whereby services are being lost or diluted to other hospitals. So just, there's a topic there, or someone made reference there about the messaging. I think it's very important that whenever we're talking about services, that we talk about services that can be gained and boosted and enhanced in hospitals as well.
So look, I think you've made a really powerful point, which I fully agree with. For me, this is about what each hospital is going to be known for the services it's going to deliver for its local community and for the region. And I think that, for example, the introduction of elective overnight stay centres in both the South West Acute Hospital and in Daisy Hill have been indications that those hospitals will have a future for the future, that there's a range of services they will continue to deliver for their local community, and then they will also provide regional services of those high volume, low complexity cases that those elective overnight centres. And that's the thing that then the likes of those hospitals that are perhaps not as large as some of the big area hospitals can undertake. As I said, the challenge with those hospitals is that if you try to deliver all the services on the one site with small teams, then the risk of unplanned collapse is greater, and that is the thing I think that strikes the greatest fear into the local population if they feel that a service is being removed without planning and without really careful thought. I know that in the case of Causeway, Jennifer Welsh, the Chief Executive of the Northern Trust, did a presentation, I think, to Causeway Coast and Glens Council the other week, setting out her vision for Causeway for the future, for example. And a lot of this is about joining up the work that's done regionally then with what this is going to mean for each locality in a way that makes sense for the people in that locality. But I think the point you make is a powerful one, so thank you.
And I suppose just on the back of that, I mean, I could have said a lot of what Alan had said around Daisy Hill in my own area, but I think it's very important that we don't confuse transformation with service collapse. No. And that's what we've been seeing, particularly in recent years, and that we know there's lots of really positive things happening. You've mentioned the elective care hub, but because of the trajectory of stuff, people's fears are always very you know, are very high around these things. And I think the basis of it all, but I mean, you know, we talked about the pay settlement at the beginning of this meeting. The crux of a lot of these issues are workforce. So until we find that we can resolve those, we're never going to get to the point where we're not seeing this. So if we can focus on a proper workforce plan, I think that will help to deal with so much more of the issues that we're seeing right across the board. So, sorry, Peter, didn't mean to interrupt you. I know we've been talking for quite a long time. It is our first meeting back, and I'm very, very conscious of officials as well and the time that you've been here. But I am going to just give a wee bit of I've got Linda, Diane and Danny, just 3 small points if we can keep it as quickly as possible. Thank you.
This is just really ties in with what we've been talking about. Whenever hospital services, our local communities feel hospital services are under threat, they see the negative, they don't see any positive, and it's because we don't see a plan. We don't, you know, we've had Bengo, we've had a numerous iterations of all these plans, but we now need to see is a plan from the department and the minister that actually sets it out. You know, if we do A, somebody, you know, does B, and I know that will be contentious and difficult. I genuinely do know that, but I think that what we've seen so far is I'm loath to use the word, but rationalisation through collapse, as the chair has said. And what we really want for the future is a proper plan for the hospitals that we can all buy into and say, this is what we need to do. And I just think that is a very powerful point and really important. You know, I'm looking at lots of plans from you today. I think that, you know, a plan for waiting lists is really important. Peter's smiling. I'll be after him for a plan for children's services too. But anyway,
so I think, and Jim has already talked a good bit about the work that we have done in preparation. What I would say is that we have seen some plan changes in recent times. The maternity at Causeway is one such example. The minor injury unit moving from Ards to the Ulster is another example. It is possible to make plan change. If we don't make plan change, then the risk of collapse grows, I'm afraid, in some areas. So that's the risk that we're always managing.
Mine is a quick question, but just on the back of that, the 3 things that need to be in that plan is, will you get a better service? Will you have a better outcome and accessibility? Because for people in a rural area, how do I get there? And that is different for everybody. I have a car, I can jump in the car, I have family. If I can't drive, they can take me. But what about people who don't have support around them, don't have access to transport? So it's about having, I'm not asking you to answer that, I'm saying those are the 3 things for me. If I can go and tell somebody, here's the 3 things that I can tell you will definitely happen for you. You will have accessibility, you will have a better outcome, you will have a better service. I think they'll get it, but we need to give them those guarantees. My question is just around the inquiries. So the trust pay for the inquiries that are obviously in their trust area. Are those paid for out of the trust budget, or is there a separate business case made to the department to finance those inquiries? So I'm talking about the likes of the urology, which would be paid for by the Southern Trust. I know some maybe might be departmental, but there are some that are certainly trust.
The cervical smear.
The cervical smear one,
So in terms of public inquiries, it's the department that establishes public inquiries and pays for the running of the public inquiry. That's my clear understanding. Right. But there will be a demand on those trusts or other organisations that need to give evidence to the public inquiry. So the Southern Trust will have been heavily involved in the urology inquiry in terms of giving evidence, providing exhibits, giving senior time to attend the inquiry, to give evidence at inquiry hearings, the need for legal support for witnesses and for the writing of statements, very similar to the way in which I described for the department for the COVID inquiry. So those are the costs that are being incurred by individual trusts, but not for the actual running of the inquiries.
Can they come with a business case for those? And just on the cervical smear one, for example, so they're unforeseen costs, and yes, the trust failed those women, I accept that, but so did the PHA. So is the Southern Trust carrying all the cost and the PHA and the department getting away on that?
So The cytology example is one that I would need to go and look at. It's not quite the same as the public inquiries because it's a different sort of an equation. But what we have said to the Trust so far is that they do need to bear their own costs, just as the Department has had to bear very substantial costs for participating in inquiries as well. So that is the position that we've adopted today. Do you want to add to that?
Well, just to add that where those costs go over the Trust budget, they will appear as pressures that they then come back to us and seek additional funding for.
Maybe just to pick up, I think there's the cost to inquiry, but there's actually the cost of doing the work to address the problem that's risen. And the answer to that is yes, it's a Trust responsibility for doing the work. However, that is like all work, and if they need assistance in that, if they need support, they can go to our performance group to say, how do we mitigate this? How do we get the list going down? So, for example, when the Trust was doing its look back in urology, it still had to continue delivering urology services, so it had to look at what mitigations it could put in place. And as Chris says, where that exceeds their budget or they have to put additional resource to it, it will appear as a cost.
And I would
yes, they
just
are responsible for
appreciate
doing that
somebody coming back to me on the cervical smear one because there was a number of failures.
Yes, okay, I'm happy to look into that one.
Yeah, down
Yeah, just in one of the presentations, I think it was yours, Jim, you had mentioned harnessing the power of community pharmacies. Now, we've all been written to recently by community pharmacy representatives. In fact, I visited one of my community pharmacists yesterday, just as a request. Now, they have sent us urgent letters about the clawback, saying that the increase in clawback in January there had went from 9.75% to 18.4%. And this had created significant financial pressures right across community pharmacy. It is something that they see making a lot of community pharmacists unsustainable, particularly in rural areas and places like that. Were you aware of what this was going to mean to the community pharmacists?
I'll pick up on that one, perhaps, if that's okay.
And just for the reason of that increase, if you wouldn't mind.
Yeah, so look, we've received a very significant number of letters from community pharmacies, and the Minister will be meeting the representative body, the Community Pharmacy Northern Ireland, next week, and that will be an opportunity to engage around the issues. So I think that, as ever, there's quite a complex cocktail of funding and different funding arrangements that community pharmacy look to, whether that be the fees they receive for the work they do, whether it be the profit margin that they're able to accrue, and then whether any clawback arrangements, if there's excess profits and so on, should apply. There have also been some complicating factors around money that was loaned to community pharmacy during COVID that is being recouped at the moment. We're nearly at the end of that process, for example. So I think it would be worth a more detailed conversation rather than trying to answer specifically here, because I think it's more complicated than just the one issue, and I think community pharmacy themselves would say it's not just one issue that is of concern to them.
Okay.
I appreciate it. Maybe that's something we can follow up. Thank you.
Okay, thank you all. I mean, I think it's been a very detailed discussion, but I'm sure you expected it, especially our first committee meeting. But we do appreciate it, and we know there's a huge amount of work ongoing and to be done. So I'm sure we'll pick up a lot of this going forward. So thank you all.
Thank you.
Okay, happy to go ahead. Okay, members, then just back, I suppose, to your pack. As we mentioned earlier, there are a number of statutory rules in which the committee needs to come to a view in the next few weeks in order to comply with the statutory period for consideration. As the examiner of statutory rules has not yet reported on these SRs, the committee's decision will be made subject to the examiner's report. And should the examiner identify an issue with an SR, this will be brought to the committee's attention at our next meeting. There are 14 SRs on the agenda for today, and I appreciate a lot of people are very new to this, and there's quite a lot of information to go through. So if anyone has any questions as we go through them, please do indicate. So the first group of SRs are concerned pension regulations. So just if I can refer you to the clerk's memo on the individual SRs and to the SR papers at pages 316 to 683 of your pack. I will go through these and as I said, if you want to indicate throughout, please do. So the first one is SR 2022-196, the Health and Social Care Pension Schemes, Additional Voluntary Contributions and Injury Benefits Amendment Regulations NI 2022, and it's at page 317 of your pack. This SR rectifies discrimination identified within health and social care pension provision and reforms final pay control. So just to ask if members are content with the SR. Yep. Content. So members, if we could ask you to agree formally then that the Committee for Health has considered SR 2022-196, Health and Social Care Pension Schemes, Additional Voluntary Contributions and Injury Benefits Amendment Regulations NI 2022, and subject to the Examiner of Statutory Rules report, have no objection to the rule. Agreed? The next one then is SR 2022-244, Health and Social Care Pension Scheme Member Contributions Amendment Regulations NI 2022 at page 355 of your pack. This SR provides new contribution bands for health and social care pension schemes in line with England and Wales. If we can ask members if they are content with the SR. Content. So just if we can ask for agreement that the Committee for Health has considered SR 2022-244 Health and Social Care Pension Scheme Member Contributions Amendment Regulations NI 2022, and subject to the Examiner of Statutory Rules report, have no objection to the rule. Members agreed? Agreed. Agreed. The next one then is SR 2022-245, the Health and Social Care Pensions Abatement Number 2 Regulations NI 2022 at page 381 of your pack. This SR extends temporary modifications to 3 health and social care pension scheme rules. Are members content with the SR? And if I can ask members to agree then that the Committee for Health has considered SR 2022-245, the Health and Social Care Pensions Abatement Number 2 Regulations 2022, and subject to the Examiner of Statutory Rules report, have no objection to the rule. Agreed. SR 2023-33, Health and Social Care Pension Scheme Amendment Regulations NI 2023, and it's on page 398 of your pack. This SR provides for technical amendments to the health and social care pension schemes to align consumer price index inflation rates and the annual allowance tax calculations. I can ask members if they're content. The Committee for Health has considered SR 2023-33 Health and Social Care Pension Scheme Amendments Regulations NI 2023, and subject to the Examiner of Statutory Rules report, had no objection to the rule. Members agreed? Agreed. SR 2023-132 Health and Social Care Pension Schemes Remediable Service Regulations NI 2023 at page 428 of your pack. This SR implements the second stage of the McLeod judgment, and asks members if they're content with the SR. The Committee for Health has considered SR 2023-132 Health and Social Care Pension Schemes Remediable Service Regulations NI 2023, and subject to the Examiner of Statutory Rules report, had no objection to the rule. Members agreed? Agreed. SR 2023-133 Firefighters Pension Remediable Service Regulations NI 2023 at page 512 of your pack. This SR also implements elements of the McLeod judgment. I can ask if members are content with the SR. Agreed. The Committee for Health has considered SR 2023-133 Firefighters Pensions Remediable Service Regulations NI 2023, and subject to the Examiner of Statutory Rules report, had no objection to the rule. Are members agreed? Agreed. SR 2023-178 Firefighters Pension Schemes Amendment Regulations NI 2023 at page 565 of your pack. This SR concerns pension rights for retained firefighters. Can I ask members if they're content with the SR? Agreed. The Committee for Health has considered SR 2023-178 Firefighters Pension Schemes Amendment Regulations NI 2023, and subject to the Examiner of Statutory Rules report, had no objection to the rule. And members agreed? Agreed. And just to advise members that the statutory period for the next 3 SRs has expired, and ask if you are content to note the following SRs. SR 2022-153, the HSC Pension Schemes Abatement Regulations NI 2022. SR 2022-155, Firefighters Pension Schemes Amendment Regulations NI 2022. and SR 2022-156 Health and Social Care Pension Schemes Amendment Regulations NI 2022. Are members happy to note?
Great.
The next group of SRs concern public health regulations and regulations regarding the provision of health service to persons not ordinarily resident. Just to refer members to the clerk's memo on the individual SRs and to the papers at tabs 649 to 683 of your pack. SR 2022-181 Public Health Notifiable Diseases Order NI 2022 on page 650. This SR makes monkeypox a notifiable disease. Just can ask members if they're content with the SR.
Great.
The Committee for Health has considered SR 2022-181 Public Health Notifiable Diseases Order NI 2022 and subject to the Examiner of Statutory Rules report have no objection to the rule. Are members agreed?
Agreed.
SR 2022-195 Provision of Health Services to Persons not ordinarily resident, Amendment Number 2 Regulations NI 2022 at page 659 of your pack, and this SR allows visitors present with monkeypox to be treated free of charge. Are members content with the SR?
Agreed.
The Committee for Health has considered provision of health services to persons not ordinarily resident, Amendment Number 2 Regulations NI 2022, and subject to the Examiner of Statutory Rules report had no objection to the rule. Members agreed?
Agreed.
SR 2023-213 the provision of health services not ordinarily resident, Amendment Regulations NI 2023, page 669. Just to inform members that this SR adds to the bailiwick of Guernsey, Iceland and Liechtenstein to the list of countries and territories with which the UK Government have entered into reciprocal agreements for the provision of healthcare. Are members content?
Agreed.
The Committee for Health has considered the provision of health services not ordinarily resident, Amendment Regulations NI 2023, and subject to the Examiner of Statutory Rules report had no objection to the rule. Are members agreed?
Agreed.
SR 2022-174 Provision of Health Services to Persons not ordinarily resident, Amendment Regulations NI 2022. The statutory period for this SR has expired, and I would ask if members are content to note.
Agreed.
Thank you, members. That is all the SRs. Item 21 of your agenda is correspondence, and just to draw members' attention to the correspondence list at page 685 of your pack. This list refers to correspondence received prior to the establishment of the committee, and the items will be forwarded to members following this meeting. If members wish to raise any issues with correspondence, they can inform the clerk so that relevant item or items can be brought to the next meeting. Members happy enough?
Yeah, agreed.
I'm sorry, Chair. I assume we're seeing these, so then we will see these.
They'll be issued, if
Yeah.
not later
Yeah.
tomorrow morning.
I'm not going to look at them tonight, so.
Quite a lot. Item 22 then is the forward work programme. So just to draw members' attention to the proposed draft forward work programme and schedule of briefings for the next 4 weeks, which is at page 690 of your pack. If I can ask the clerk to outline the forward work programme, please.
Thanks, Chair. Again, as mentioned before, next week we have the Chief Executives of the Trusts coming. They'll be first up, and we have like I said, we've booked a room from 1 to 2 for them, so maybe from about 1:30 if members want to call in, we'll provide the details of where it is and time. If you want to call in for an informal chat, first of all, it's completely up to members, but then we'll have that, and then unfortunately with more SRs to go through, and we've one in particular next week where we'll have officials along, and that's in relation to some of the COVID regs. So it is, and it's one that was there at the end of the last mandate where they extended the ability to make regulations under for COVID, and it's the latest one. So I think this might be the third extension in the last couple of years. So we have officials up on that next week. The following week then we have the budget briefing from the department, so we'll be able to ask a bit more detail on the budget and also on the capital projects. We'll have officials on the capital projects as well. The week after that, then we're looking at transformation, and we'll briefing from the lead officials on that. And the week after that then is waiting lists, where we would hope to have officials on it, and then the Royal College of Surgeons as well to brief. And like I said, that's the first sort of 4 weeks. There will be a couple of other wee things that, as they come along, maybe some more statutory rules over the next couple of weeks, where but again, we'll provide more information on those. But that's certainly the initial 4-week period.
Thank you, Linda.
I'm content with the forward work plan. Sorry, just to say that first. Just going forward, I didn't want to go over stuff that had already been asked about the review of children's services, and we need to wait to see what kind of their thinking is a bit. But we also need to establish our own thinking and start to get some, I think, start to get talking to a range of people, including maybe Rachel. I mean, I'm not hard and fast on who we speak to, but it goes back to what Colin said earlier on. I would like to have all the information before that will be coming on top of us, and then we're saying what's our position here. So, for example, if the the officials came and said that, we're minded to establish an arm's length body, and we may not be able to have a committee position on that, and that's not the end of the world if we can't, but it'd be great if we could. And I don't have, again, a hard and fast idea of what we would want to do in that, but I definitely would want to get my head around it. And we shouldn't be left that's what we're focused entirely on, because for me, why are so many young people ending up in the position where they're looked after children in the first place? And that's the big issue. Where are the early interventions? Where are the support for families? So I think at some point we want to get I'm not looking for it to go on, and I just want to flag it up as an issue that we want to be looking at.
Would support that if such a big thing came out and there was no executive. I think we need to.
Yeah.
I absolutely have no problem with that. I think it's really, really important. And we need to, I kind of would like to see these are really big issues that we're going to deal with in the first number of weeks, and that's fine. And we'll all, I'm new to health, so I will grapple with understanding all of the implications of that. I just wanted to know the committee's view on kind of our own kind of mini inquiries into services that are lacking, and one of those that I would like the committee to consider is services for adults who have been diagnosed with ADHD. There are none in Northern Ireland is the short answer, and it is an increasing issue. That what happens to you after the age of 18 if you're diagnosed, and in the Southern Trust area you're simply told to go and seek mental health advice, but you don't have a mental health problem, you have ADHD. And I was just wondering the committee's view on our own kind of little mini inquiries as to, and I know there's a lot of work and it's new and all the rest of it, but I just want to put that in the record, that I think those kind of things where there are just simply no services in Northern Ireland at all are quite important.
Yeah, and I mean, I suppose there's quite a few things that maybe an informal session with the committee to look at what of those issues that we have, as a committee, and then kind of prioritise where we fit them in terms of.
No, I'm not against it. I just want to.
Yeah, no, but I think that's important, because there's so many things we probably have to deal with that have been outstanding.
Yes.
And now we now have maybe new issues like that. I mean, autism services for adults is another example of how there's little to no service beyond a certain point. So I think that would be good, even if we sat as a committee and kind of thrashed out some of those things and get them on, on a programme that we can.
Yeah, Chair, just to say that the plan will include a couple of weeks towards the end of sort of the 8-9 weeks where we can have time to talk about priorities sort of over the next, you're probably looking until next June. So it is, but that would be the idea. We might come up with 3 or 4 areas that we'd want to focus on.
I just think people are watching very carefully, and we can talk about the big issues, and that's really necessary, But why is it in some areas we just have no services at all?
Yeah, no, I think that's a good point, and we did. I mean, Orly had raised the question around health inequalities and things like that. So some of that will feed into, you know, the services and what's available. Sorry, Colin, we were waiting to come in.
No, and actually it's on probably the similar thing that you've said about the opportunity for us as a committee to decide what our priorities are, and like certainly not wanting to sound in any way like Johnny Know-it-all, but like I've been health spokesperson for our party for about 5 years. Believe me, if you're new to this, you're about to realise that there are dozens and dozens and dozens of groups out there, and every last one of them is going to be at you saying that theirs is the most important issue, and they can tell you how many people are impacted by it, and it's never ending. Your diary as a health spokesperson is every week there's 1 or 2 organisations coming, so how we funnel that in. But if there's an opportunity for us to informally meet to be able to try and set those priorities, because again from the last time on the committee we might get really 2 or 3 bites at issues, so how we work out what those issues are going to be whenever there are literally, you know, dozens. I mean, I don't know if people noticed, we had about 3 or 4 groups, representative groups that were in the audience today, and you can see that they were sharpening down with their notes to try and work out how they're going to come back to us after today's meeting to say, what are you going to do for chest, heart and stroke, what are you going to do for other bits and pieces, because they'll want us to deliver their work. But maybe if there's a thematic way, because I think we're Diana sort of saying that there's ADHD where there's no services in some places and some in other, that actually might cut across about 5 or 6 different conditions or different ways. So is there a thematic thing about access to services, or do you know, maybe like if instead of picking one particular cancer, we might say what's the access to the ability to get diagnosis across all cancers, but there might be key higher level themes that we could investigate that might allow us to, rather than picking on very individual, but if we got a chance to meet as informally to come up with those plans, it would be really good.
Yeah.
Sure. Can I just, given that we all have different committees that we try to work out,
It
doesn't clash. So for example, Linda and I, Thursday mornings just is no good. I know it's an added task to your list.
Yeah.
I'd be more than willing to meet informally at a different time, and I think that's a really good idea around the priorities.
Yeah. And I suppose it's just as we sort of touched on at the start when we're going through procedure and things, it's looking at the most effective use of the committee. And what could we be doing, I suppose, outside of that will still have this, you know, that we're still having the same impact. So we can tease all of that out over the next couple of weeks, I think, anyway. So just, I suppose, on the basis of that conversation, our members happy to proceed with the briefing as set out in the work programme so far?
Yep.
Yeah. Thank you. The only other thing then, any other business, does anyone have any items of business they wish to raise at this stage? If I can just use the opportunity to wish Deirdre all the best. Very conscious, quite a heavy one today, and then now you're heading off. But just to wish you all the best, and thanks for coming today. Thank you, and thanks to the team who will now be working for a wee while under resourced, like everything we've talked about today. But you know, we'll try to be very mindful of that as well. So moving forward. So members, just the next meeting is next Thursday, the 22nd of February at 2 p.m. in room 29. So thank you all for your time today, and this meeting is adjourned.
Committee Room 29.